this meeting as we have separate links. So we're still waiting for Claire to join us back from the other link that she had. As soon as she's in, we'll get started with her talk. A bit of housekeeping. We're going to have a comfort break at 10 minutes past 1. Both speakers are quite happy for the talk to be interactive. So whenever you have a question, please raise your hand. I'll call you and bring you to ask questions and discussion. We will have separate discussions since the topics are different. So after Claire's talk, there'll be a period for us to debate. And then after Tom's, we'll do the same and finish hopefully on time at 2 p.m. Here we go. So welcome, Claire, to the meeting. I think you should be connected now. I see that your microphone is on. Okay.
I am. Thank you. Yes. I went out from one Teams to another, but I'll share my screen then. Let's just see.
I think Clare Bailey doesn't need much introduction. She's an eminent medical retina consultant and one of the leading lights of the Bristol Eye Hospital. She's pioneered many new ways of working in ophthalmology, not least remote intravitreal injection clinics, depending from the main hub site. She's been hugely active in the recovery of the Bristol Hospital from the pandemic. Lately, setting up our own imaging hub to transform elective care, and this success is what she is going to talk to us today. So very many thanks, Claire. The microphone is yours.
Pleasure. Just checking you can see my slides okay, Johan, can you? Yeah.
Yes, thank you.
Good, lovely. Well, it's a great pleasure to be here. So I wanted to sort of talk you through, the implementation of our imaging hub in Bristol. It was a massive team effort, and I'll sort of try and take you through sort of where we were at the start of the pandemic and sort of how things have evolved. So our local catchment population is more than 1 million, although we do take regional referrals, from a wider area as well. But the core catchment population of our CCGs, which is called BNSSG, is just over 1 million. And prior to the pandemic, we had already done quite a bit of modernising. So we had a hub and spoke model of care with outreach anti-VEGF services at 3 other locations, including a mobile treatment unit in a large shopping centre supermarket car park. And that was using networked imaging and electronic patient records. We've had Medisoft EPR for many years. And also we had been running virtual clinics for certain medical retina patients over many years. And that was limited in case mix by having only one Optos wide field camera at the time. So I guess the backdrop to where we were was at least some of the building blocks were there because we had electronic patient records, and so that helped. And as in many places, in fact all places really, with the COVID first wave, all non-urgent treatments stopped. Many non-urgent clinic appointments were cancelled, and we triaged all of the cancelled appointments according to the level of urgency. And in medical retina, the team, and this was led by a couple of my consultant colleagues and some brilliant shared care optometrists we had, they went through all of the medical retina follow-up cases and triaged them according to the diagnosis, the urgency, and whether they were suitable for a virtual clinic or not. And that made things a lot easier when we eventually got things set up. Glaucoma patients, which again are the major kind of follow-up capacity issues, they had already been organised into suspect, stable and complex glaucoma cohorts, so that was very helpful. And we rapidly realised, early on in 2020 that the size of the COVID-related backlogs was, necessitated planning to very significantly increase capacity. And once non-urgent work restarted, our face-to-face capacity was only approximately 50% of pre-COVID levels at the eye hospital with the social distancing requirement. So we went into this quite early on in the pandemic with 2 models of care. A high volume off-site imaging hub using networked imaging and EPR, and then also close working with community optometry to upscale community care and imaging. And I'll talk a little bit about that at the end. And when we were looking at what our, outpatient follow-up delays, we realised that that was the biggest risk for irreversible sight loss within the eye hospital as a result of the pandemic. So we put forward a business case based on the equipment and staffing requirements for 3 streams for medical retina, 4 streams for glaucoma work, and 1 stream for keratoconus follow-up. And this went through a sort of series of different approval processes. It was a little bit unclear to start with quite where it needed to go, but we had approval from our division, then the trust executives, as well as approval from a regional COVID recovery committee. And I wanted to really, to state how brilliant the management team of the eye hospital has been throughout all of this. We've had completely exceptional management who've really, really supported this concept, and an outstanding project manager called Jan Belcher, who I will talk about later, who really facilitated all of this being set up efficiently. So the practical challenges to this sort of concept were space, because we've certainly got no space in the eye hospital. It's completely jam-packed. Staffing, because we did not have, free staff to be doing these imaging requirements. Clearly, setting up such a process would need quite a lot of administrative organisation. And then it's all very well taking the images, but you need to have a really well-oiled grading structure so that you can actually grade all the images and feed back to patients in a timely manner. So in terms of space, we reviewed a number of different locations at the time, and it turned out that our local Nightingale hospital was empty and already had IT connectivity in place. So that seemed an ideal option, albeit was never going to be a permanent option. But because it was time was of the essence, so we didn't get 2 huge backlogs, a decision was made to use the local Nightingale while it was available. And capacity modelling has demonstrated to the trust executive team the need for this capacity to continue for the longer term. So I'm going to talk about how we set things up in our Nightingale. But when the Nightingales got decommissioned nationally, we've moved into an interim location, but the trust has approved a permanent location opening. So in terms of the model of care for medical retina, the patients in the pathway will have a vision, which is done with a mini logmar chart. They're then dilated. They have wide field imaging using the Optos California, and they have colours and autofluorescence in all cases. They have a spectral domain OCT, and we bought Topcon Tritons for this purpose. Eye care is available, so patients can have IOP tested, such as proliferative diabetics or vein occlusions. And with the need to clean the equipment and having done a bit of piloting this way, the imaging team said that they could image 18 patients per session per stream 5 days a week. So that with the 3 streams would mean that we had a capacity of 540 patients per week. And we put in a wide case mix, although diabetic retinopathy does make up the majority of cases. And this is how things looked in the Nightingale. So patients came in and had their vision done. You can see on the left on the mini logmar chart. They were then dilated and they sat in a little next bay along, because space was really not an issue in this huge, vast Nightingale, which was the conference centre at the University of West of England. So they sat in the waiting area, a little bay, while they were dilating, and then they went through, and one of the imagers did the OCT and the Optos in the next bay, and then they'd go home. So they were in and out in less than 20 minutes. And in glaucoma, things were slightly different because the team wanted to make sure the patients were taking the drops that we thought they should be on. So they were given a questionnaire in advance to report back on, what drops they were actually taking and whether they had any symptoms or whatever. And that data was entered onto the electronic patient records by the technicians. They had a visual field test. They had a visual acuity, again with mini logmar IOP. They were dilated. Initially, we didn't dilate them, but actually we found that there were far fewer ungradable images by dilating them, so they now are all dilated. And they had an OCT taken of the disc of the macula. And because that was a slightly different, slightly more time-consuming system, the imaging team and technicians felt they could see 11 patients per session with 4 streams. That was 440 patients per week at maximum capacity. So, similar pictures really to the medical retina streams. They have their vision done. They have another bay where they have a visual field, and then they have another bay where they go through to have their OCT taken. And in terms of, quite a lot of people have asked about staffing, so I thought it was helpful to show you know, what we have. So we've tried where possible to use, you know, technicians. So we have band 3 technicians, and we have one of them per stream, so 3 in total for medical retina, and they do the visual acuity, the IOP if needs be, and put the dilating drops in. And then what we have are, for when we have 3 streams, we have 2 band 4 imaging team, but we wanted to have 1 band 5 available. And the idea of the senior support was to troubleshoot, help if there were difficult to image patients. And I think that's really helped to reduce the number of ungradable images, which have been very, very low, which is incredibly pleasing. So we have 2 band 4s and 1 band 5 when we have the 3 streams of the Nightingale. And for glaucoma, we have band 4s that do the questionnaire, the vision, OCT and IOP. The visual fields are done by band 3s, and then they had a support role to allow the streams to flow, because there's a little bit more going in and out for the glaucoma team, and that was a band 3 person. But there really needed to be quite a lot of other staffing aspects to think about. So we had managerial support from other existing staff. So we had a band 7 nursing lead who massively had input, massive input from the imaging lead, and we had an admin process lead and consultant input from the relevant subspecialty services. And the project manager was a massively key role. This was our marvellous colleague Jan Belcher, who was already in post, a brilliant project manager, and she initially dedicated 2 days per week, but that rose to 4 days per week prior to the clinic commencing. And she really sort of brought everything together, organised the very regular meetings, and was completely superb. We also have an on-site nurse coordinator, band 6, responsible for patient safety and operational staff management. And we also you also need to think about admin staffing. So we had one whole-time equivalent band 3 booking coordinator, because there was a lot more appointments to be booked, 1 whole-time equivalent band 2 admin support, and 2.9 band 2 reception were appointed to allow for continuous cover, because the idea was that these clinics would run the entire year, Monday to Friday. So in total, we had 29 new members of staff for the entire hub. And one of the things we felt was really important was to get a rapid turnaround from approval of the posts to actually getting them appointed, and then for them to start work and be trained up to do the roles. So we had very, very specific skill-focused training for the band 3s and 4s coming in, some of whom had done no ophthalmology before. They were trained up to do certain roles, and then as they got more trained up, they could expand on to do other roles. And we used the UCL online training course to supplement local training. We thought this was an outstanding course for people who've never done ophthalmology. It explains all sorts of terminology that you might come across in the field of ophthalmology that we all take for granted. And we sort of bought a job lot of that, and that supplemented the local training. So we liked that course. Now, in terms of the grading processes, we did quite a lot of reorganising to get all this running very slickly. So the grading is largely done by the multidisciplinary team. So we've been lucky in Bristol to have for many years some outstanding shared care optometrists who are at band 8A level. And they basically deal with the primary grading for both glaucoma and medical retina. They needed timetable adjustments to make sure that the grading requirements were all covered. And we did some pilot work, because before we went into the Nightingale, we were doing virtual work at weekends. And we worked out that they could grade 18 cases per clinic. That was manageable, and that involved, fully writing up the Medisoft electronic patient records and writing the letter to the patient, etc., etc. So we could do 18 for medical retina and 11 cases per session for glaucoma. In terms of what we put in the medical retina clinics, then we had really quite a wide case mix of follow-ups. Because the backlogs were so enormous, we felt that actually it was better that they were seen than have further delays waiting for face-to-face. We actually put a very wide case mix of follow-ups, but it's true to say that because of the case mix, the vast majority still are diabetic retinopathy. And in glaucoma, they were stable glaucoma patients and patients with ocular hypertension. So we created some SOPs. and circulated clinical guidelines to the team. So we have a separate SOP for medical retina and a separate one for glaucoma. We use the Medisoft electronic patient record, so it's the entirely paperless process, and we outcome the appointments directly onto our PAS system that's called Medway. And the SOP basically also contained advice about which cases to request a telephone consultation or a second opinion. And we had processes for urgent cases where they could be reviewed. And those that had requested teleconsultations or second opinions are all booked and logged on the Medway booking system. And teleconsultations in medical retina are undertaken by consultants. And there's a secure dedicated email for queries to the glaucoma consultant. So they had a slightly separate system. So we set up a formal timetable with named individuals responsible for grading particular clinics. We thought that was important to prevent sort of a pile and building up and people not being kind of accountable for what they were doing. And generally these would be graded within 24 hours of the imaging appointment with cross-cover arrangements as well. And the admin team then send off the letters to the patient once the timetable grading sessions occurred. And the GP letters automatically go to the clinical document service, CDS. And the target is patients should receive their letters within 2 weeks maximum of the imaging appointment. In terms of teleconsultations for medical retina, these are undertaken by consultants, and the sort of cases that would go for a teleconsultation are those, for instance, that might require PRP or macular laser or anti-VEGF treatment. So what we tried to do was keep those ones out of the face-to-face for that discussion. We're trying to sort of keep our precious face-to-face for those that really, really have to be seen face-to-face. So I would typically discuss that risks and benefits over the telephone with the patient in a booked telephone consultation. And I would then list them for treatment as appropriate, and then the consent form would be sort of signed off on the day of treatment. And some teleconsultations would occur where a further history was needed or other discussions around further investigations. And we sort of worked out actually that 12 cases booked per session for teleconsultations was the best method. So they're booked, so the patient knows to expect a phone call at, say, 9 AM, and that works really well. You're much more likely to get hold of the patients if they know to expect your call and they don't think you're cold calling them, etc. So that works out well, because obviously this is a sort of more of a complicated group of patients that might need longer chats about the risks and benefits of treatment and things. In terms of patient numbers, well, in terms of the Nightingale, we only started in November 2020 with just a small amount. Well, we were setting it up 7 patients in one stream. But by the 31st of March 2021, we'd seen nearly 7,200 patients with 4 glaucoma and 3 medical retina streams. And that, with those 7 streams, was 195 patients per day. There was a questionnaire given to the patients, and this was very, very good feedback. They, the vast majority thought it was excellent or very good care. And certainly the feedback I've got from doing many, many telephone consultation clinics is that the patients actually really loved it because they were there for far less time. They were in and out within 20 minutes. They get a letter back, if it's straightforward, and they get a telephone consultation with the consultant if it's not. And I feel as a consultant that I've got a far better overview over far, far more patients than I ever had prior to this being set up. So as I said, we had to close in the Nightingale, but we demonstrated the efficiency of the service, and we're due to be moving into an empty retail outlet in a shopping centre very close to the Bristol Eye Hospital very soon. So I think it was the right decision to go into the Nightingale, although a bit frustrating that we had to move out when we did. And so really very, very briefly, I just wanted to update you on the second part of our capacity management thing, which was having closer liaison with community optometrists. So we bid for some NHS-X funds in 2021. This was technically part of called electronic referral system bids, but we felt that actually what we'd like to do is have a system where we could do better two-way communication with community optometrists. So the group that we had a slightly different bid for our BNSSG area than they did in the rest of the Southwest. And the group that won the bid were Topcon Harmony, and this is currently in setup. So they're the first thing they have to do is link up all the equipment within the eye hospital. But as part of that funding, we have licenses for all of the 91 optometric practices in our local area if they wish to participate. And the pilot is due to start soon for stable glaucoma patients. So it's effectively a bit like a mini hub, really, in the sense that they will have imaging, IOP and fields in the community optometry locations. And the images and results are uploaded via Topcon Harmony onto the cloud, which we can then see in their entirety. And our imaging team can grade them. So it's very, very different, very, very similar in concept to the imaging hub. We couldn't set this up instantly at the start of the pandemic because A, we didn't have the linking with Topcon Harmony, and B, the optometrists wouldn't have had sufficient capacity to get us up and running really, really quickly. But there are huge opportunities once we've rolled out the pilot and got things licked into shape with the stable glaucoma patients. There are huge opportunities in other specialties. Obviously, medical retina being my field, I can see, there's huge opportunities with us being able to peruse the entire OCT scan, and we could essentially not need to bring people to the eye hospital for, in certain circumstances. It's certainly true, I think, across the UK that in sort of wet AMD triage clinics in hospitals, often only about 50% of the cases have actually got wet AMD. So if you can sort of filter them out by looking at the community optometrists' OCTs and perhaps giving telephone advice or feeding back to the optometrist, that will make the model more efficient. So, I won't talk for too long as there may be some questions, but essentially, our imaging hub at the Nightingale Hospital demonstrated the efficiency of the service. Patient feedback's been very positive, and the capacity modelling demonstrated the need for this as a permanent model of care, which the Trust have supported. And as I said, the work is speeding ahead, setting up these data acquisition mini hubs at community optometric locations as well. Thanks. So I'm very happy to answer any questions.
Thank you very much, Claire, for that amazing presentation. I'm witness to the success of this process and how the ongoing issue of risk to patients from waiting too long on a payment list has been dramatically impacted by this success. So we'll open now the floor for any questions from the audience. So put your hands up or make yourself known otherwise. Whilst we wait, I'd like to ask you, so obviously as doctors we're most interested in patient safety, patient care, patient quality, but there has to be a financial support to these that our managers would be most interested. And I guess this would be key to success, to replicating and scaling this up elsewhere. Can you tell us how these conversations went when you were setting up this together with Jan Belcher?
Yes, well, I think, I suppose, in a way, it's one of these things where COVID really helped, because actually for years we've wanted more imaging equipment, but it was really hard to get it because the crisis was so awful. I think people really understood. It swept away echelons in a way of things that were going to make it difficult. So we explained that, given our face-to-face, I think the capacity modelling is key because we could show them, the backlogs, the fact that this was our current capacity going forward face to face, and these were the many thousands of people that weren't going to be seen. And I think that was what really did it. But going forward, I think it's a very powerful model because if you compare how many you can see face to face, and even if you had unlimited space, you see fewer people face to face versus this model, which, in some of the mini hubs, they'll be closer to patients' home as well. You can image 18 a clinic and you can't see 18 patients and imaging grade 18 medical retina patients. And you certainly can't do that in a face-to-face clinic. So what it does is really triage your patients so that the more straightforward ones can be seen virtually, and that means the face-to-face ones are really those that have to be seen face-to-face. So I think the managers like it for that reason.
Great. I also see that you've embedded staff training into the system, which of course with the great resigning that COVID also brought to us, has been a big challenge to staff. services, and it's not just healthcare, it's across society. I wonder if you've got any thinking into how you can attract and retain staff that will be motivated to carry out this work, because it's a crucial underpinning of getting this done effectively.
Well, I think career progression is key. I think we actually found recruitment of the band 3s, brand new people who've never worked in healthcare. That was fine, but I think it's retaining people as well. We've known, for years it's hard. You get a lot of nursing turnover and you get a lot of technician turnover. But I think it's really important to have a career progression. So you should be able to move from band 3 to band 4, band 5, and then in a lot of places, there can be blocks because there aren't more of the higher level things. Personally, if I had my way, but this is big national changes that would have to happen, I would love it if we could have technicians trained up to do other things, including intravitreal injections, because we don't even have a big enough pool of nurse injectors. The problem with that is that, as it stands, I think it's all to do with the insurance, schemes for trusts. They have to be registered with a professional body, which is limiting that. But you see, that would give some more potential career progression because they could go up to band 6 level as well for those that were interested. But I think it's the same in all walks of management. It's nice to have career progression.
So we have a number of questions from the floor. We've got Faris Zakaria from Ashford asking what the conversion rate is from virtual to face-to-face reviews.
Well, in medical retina, it's extremely low because the graders, the optometrists, don't book them into face-to-face. They can't book them into face-to-face directly themselves. That goes via a teleconsultation with a consultant. And so it's a question of how you define it, because if they need treatment, they'll come to a teleconsultation, say I would do that, and then I would book them in for their treatment. But that was not what I would call a face-to-face clinic visit. That's a treatment visit. So the very, very few are coming back. Now, I do think that there will be, as ours matures, and this is what we're planning to do in our new location, is to have a slit lamp. And it's not to say we're going back to face-to-face, but the one thing I've really noticed, it's the concurrent cataract. And it's not that it's caused the images to be ungradable, it's that what would happen is they'd come and their vision was noted to be slightly reduced. Those would get put through to a teleconsultation so that I or one of my colleagues could have a chat with them. Now, oftentimes they'll say, oh yes, I've been to my optometrist, they say I've got a bit of cataract, and because there are multiple providers, that's absolutely fine. And I'll say, well, if you've already been referred, wherever you want to go, blah, blah, blah. But it's slightly more problematic because we're so used to assessing them in the hospitalised service with their cataract. So I can envisage, and I think there's, I've been talking to colleagues around the UK, I can envisage it being quite clever to have a hybrid model where sometimes you see people on a slit lamp and sometimes you don't. And in fact, what we're probably going to do is have an optometrist with a slit lamp in our new location, and maybe they could just quickly look at the anterior segment as they go out in certain cohorts that we say, look at the cataract next time. So some of them I might say, okay, we'll see you face to face next time. But and I audited it, and there were hardly any where I said this virtual pathway hasn't worked. You need to come soon to a face to face. Hardly any, because, and I have to say, I think the Optos California images are utterly outstanding. I would argue better than trying to look on a slit lamp with a steamy lens and masks and glasses and things. So I feel slightly bereft actually in the face-to-face clinics now if I don't have a lovely wide field image to go with it, but that might just be my personal view.
So that ties also with Sonia McDarry's question from Warrington. She's asked also about the ratio face-to-face, which we touch upon. She's also wondering whether there was a limit to how many virtual appointments you had before face-to-face was arranged.
Well, yes, that's a very, very, this is what I mean about the system maturing. So while you're in the COVID crisis, you're better off, you're often better to see them. But as it matures and it kind of, the backlogs are cleared, then you start working to hone what is the perfect system, because, there's no question that there are benefits for I mean, clearly certain aspects face-to-face you can assess different things, but also having a chat to the patient is a very good idea as well, periodically, to explain about glycemic control and blood pressure control, etc. So my guess is that, you know, as it matures, this will be the hybrid model, that you make sure that periodically people are seen face to face and they'd have an interim imaging visit. So I think that's the way it's all going to head. Yeah.
And he's also asking whether patient symptoms are recorded at the diagnostic visit. I think you said yes for glaucoma patients. What happens to the medical?
So for glaucoma, yes, in the questionnaire. For medical retina, they are sort of. It's not, they're not given a questionnaire, but the technicians will say, how are you? You know, is there anything you want to report? And what they do is they write comments, and this happens quite frequently. They write comments on Medisoft that are then viewable by the grader. And those are the sort of ones that they would sometimes come through to a teleconsultation because they've got some symptoms that might need assessing. You know, it might be they've got a slightly gritty eye or something else they want to ask, and so, you know, a few of them will come through to teleconsultations. But yes, the graders will see all that and pass that on.
And this is Sakari again. Wanted to ask whether how did the conversion work in the glaucoma pathway? How
did
the glaucoma conversion rate to face-to-face review in the glaucoma pathway?
Yes, so I'm probably not, because I'm not glaucoma specialist, I don't have those figures quite as to hand as my medical retina ones, but because they just were putting in stable glaucoma patients, I think there were a proportion that had progressed, partly because there'd been delays and things, and they might come through, but I'm afraid I don't know that figure, but it's not high. The biggest difference was dilating the patients. I'd strongly urge dilatation for that pathway, because that made the ungradables a lot lower, because it's just really annoying if you can't quite get the information from the images.
I have another question from Sarah Channing at Moorfields, asking that whether the presence of a more senior tech in your hub allows you to flex the pathway, for example, when you have IB only checks for low risk ocular hypertension.
Well, I think having higher banding, certainly for the imaging staff, we found in retina made a big difference, because that you will have some patients that are difficult to position and difficult to image, and having really experienced people made a difference. For the glaucoma pathways, I mean, they have the same, whether they're ocular hypertensive or stable glaucoma, they all got the same sort of imaging. So I'm not sure if I quite understood the banding in terms of that.
I guess is whether, suppose you need a review for a uncomplicated patient on the glaucoma pathway, say somebody with ocular hypertension but no glaucoma, if they re-attend, will they go again through imaging, visual fields tests and so on, rather than only having eye pressure check?
Yes, so they all get in the hub the ocular, well, it's a bit complicated, because in our patch there is also a community scheme for certain ocular hypertensives that are not coming to the hospital, but essentially they all get the same pathway, whatever they've got in the hub from the glaucoma service, be it low risk or higher risk, and they're graded by the shared care optometrist, because they've been working in the glaucoma clinic for years, and then the next follow-up is determined by what they've already got, so that how far ahead is determined by that. And in medical retina, we wrote these very detailed guidelines, really, to try and harmonize the next follow-up period, because we used to find, and it would happen, I'm sure it happens in lots of other units, you know, you'd get a new fellow coming in, and even though you'd show them the guidelines, sort of when, you know, a few months later, you realise they've been bringing lots of people back every 3 months or something like that, or every 4 months. And so we put quite clear guidelines about what grade, what interval they should come back. And I think that really helped as well. So, and then the glaucoma team do the same.
So thanks very much, Claire. I think we're going to take a pause now until 1:15. To go on to the next talk by Tom Thorne. So I'm going to switch my camera off and I'll see you all back at 13:15. Thank you. Thanks again.
Bye.
Thank you.
Okay, welcome back for the second part of this month's UKOA seminar on transformation of eye services in the context of recovery from the pandemic, COVID-19. It's now a pleasure to introduce Tom Thorne, who is Head of Service Development for Newmedica, who is an independent sector ophthalmology care provider, one that I'm associated with. Tom is standing for Karen Crocker, who is not able to be with us today. So thank you very much, Tom, for stepping up at such short notice. The talk today is going to focus on the quality of care and productivity and how this is carried out in one of the several independent sector providers, to see whether that experience is something that can be applicable to our work as NHS providers. So thank you very much, Tom. The microphone is yours.
Perfect. I'll start to share my screen. You should be able to see me there. Okay, so as Johan said, I currently work for Newmedica. And to give a little bit of background to me, I've been in optics for about 25 years. A part of that was ophthalmology for about 6 or 7. And then I came back into ophthalmology at the beginning of this year to Newmedica. And so I wanted to give you a little bit of background about me and also about the role that I do, so you can understand how that kind of complements what we do in the industry. So my role has 3 key components, or 3 key aspects. The first one is supporting the delivery of world-class clinical standards, which we strive for. And the way we do that is we review data daily, weekly and monthly with our colleagues to improve every aspect of our clinical environment and how we provide care. The second part is to optimise and protect the patient experience. And I think that's one of the ones where, as a non-clinician myself, I try to look at this as if I was a patient. So we seek feedback on what can be improved and constantly challenging the status quo to ensure that every decision we make is to improve the experience and the outcome for every patient, because every patient's needs are slightly different. And then the third part is all around supporting the development of each strategy plan. So we take in the data we produce, we meet with our colleagues on a regular basis to focus on the areas that enable us to get marginal gains in the outcomes and the experience we deliver. And the reason why I say marginal gains, as those are the small tweaks that make a massive difference to our patients. And part of that is the way we do it. So my role is to make sure that I'm very honest with the people I work with. We have full transparency in the way we work, and I referenced this piece about intelligent challenge. Now, I'd like to pretend that I can sit in the category of intelligent, but intelligent challenge is all about looking at those things that constantly come up. So part of my role is to go to lots and lots of different outpatient buildings and other hospitals. And my role is to share the things that I've seen and help to pay that forward so it can either be replicated or just simply copied. And part of working with lots and lots of different people, I get to see that variety all the time. So the beauty of my role is I'm able to then share that experience with them, and then it's how we adapt that in their environment. Now, there's 2 key things that Karen, my colleague, wanted to talk about today, which is around productivity and versus the kind of the quality of patient care. And the reality is productivity is a very visible and very continuous and readily understood situation, and we directly measure that so that it's a daily metric, so that we can ensure that we are giving the right patient care to the right patients. And then that leads to quality patient care. So on the other hand, you know, this is very often invisible, so you can't always see it. It very often is discontinuous, it's indirect, and you know, very often success is measured by the absence of negative outcomes. So we constantly ask for feedback on what we can do to improve the patient care and journey that every patient receives. So what we do is we tend to focus around 4 key aspects. And I phrased it here of where do we start, because there isn't always a starting point, but the key is to address all of the aspects. So the 4 key areas to consider or review, and we'll start with perhaps process. So from a process perspective, we try to reduce underutilization. So using the telephone touch points with patients, we remind them to therefore enable them to get the care they need. Because very often, reminders get sent out by letter, but actually that telephone touch point, as long as the patient agrees to that, we will do that so that they get the care they need. An efficient use of consultation time, and that the whole idea is to help patients to be better informed before they come, because if they're more informed of what they need to bring or to walk through with us, we can enable that appointment to be in the correct measured time. And then quality and efficient consultation time. So we make sure that every patient gets the quality they need in the most efficient time that they want to have. Because as we know, each patient is very, very different. And so we've got that flexibility within our clinics to enable that flex where required, but also so that they get the quality and the stimulus required to achieve the goal we're looking to achieve. Now, the way we do that is we eliminate specialty referrals. So we have the beauty of being an ophthalmology only business, therefore, or clinic, and they are disease specific clinics. So we minimize that kind of generalist opportunity and focus on aspects which enables this kind of efficient use of consultation time. And then we simplify and standardize the documentation. And that's for clinical practice, but also for audit purposes, so that we can have, people that work within our services that could, in theory, be on bank within multiple services and be able to deliver the same level of care for consistency. The second stage, people, and Claire mentioned earlier how important it is for development of people, and also how we look after people for the future and how they see a future and development in their career. And so we upskill and train clinical assistants, optometrists, registered nurses, and all of our colleagues associated with giving care to our patients. And the way we do that is we bespoke the internal training. So we create internal training programs for either staff groups or individuals, and very clear training plans, which is linked to competency sign-offs. So we can ensure the consistency is absolutely where we want it to be. And then the final piece is we match the work to the worker. And, as I said, my career has been in optics, not necessarily just in ophthalmology, but obviously it's been in healthcare, and we very much play people to their strengths. We give them the things that they're really good at and match their skill set, and we develop the skills that they want to develop through their career so they can be more successful with us. The next element is pathways. And obviously one of the things we do is we map out each step of the process by the clinical pathway to ensure we make clinically informed judgments on resources, diagnostics, and also time. And you can see an example here of, how many rooms we have, to how many people we have, to how long the slot should take, and how we help to ensure that that journey is followed in a consistent and appropriate manner. And we've got that with every single one of our treatments. The third element of this, or part of the final element of this, is actually the infrastructure. So the infrastructure probably is the one that, I guess, in this forum allows us to make lots of different decisions, because the buildings are designed specifically for ophthalmic patient flow. We take the pathways and design the outpatient and the surgical spaces all around those pathways. We get the clinical team involved to ensure the journey is right, and that's from, as the building is built, we involve the theatre and the outpatient teams and our clinicians to input on every element to make sure it's right for the patient, which ultimately will reflect in patient experience and clinical outcomes and, probably efficiency too. And by having the right things in the right place at the right time of the patient journey. And I've experienced this in my past where, we've built hospitals and the sinks are too low, or the style of taps, somebody's had a different idea and perhaps not considered the people that actually use it. And this is a constant review all the time during the build and thereafter. So we then map the designs for the patient's needs. And Karen's not here today, but she would definitely want me to talk about assurance and audit as part of a bigger part of her role, which is all around how we ensure the standardisation of pathways is upkept, and decision making allowance for robust internal audit and the comparison of practice, to again pay forward that excellence that we see across our different services. And we may all have slightly different methods based on the way in which the referrals either come to us or the way in which we are defined by the pathways, but there's real key elements that we do use together to really think about how do we get those marginal gains to get even better care to our patients. And so it then comes back to these two things, which is, this productivity and quality patient care. And I guess you could say productivity or efficiency, quality care, comes hand in hand, and this must only be focused on the patient outcome. And to truly live by our values, which is better sight and health for everyone. So I guess that's probably me, Johan, in terms of where we're at as a group function, but also how we care for our patients.
Thanks, Tom, for that overview of productivity and safety and quality in care in ophthalmic from the independent sector. I was wondering if there are any questions from the floor. Please, you can put them in the chat or raise your hands. In the meantime, so the point where I'm coming from in inviting an independent sector provider to this forum is because often, so I see your background is mostly in the independent sector in optics. Mine is in NHS, with now plenty of experience overseas in the independent sector and public sector overseas, and independent sector in the UK. And it's often made a point that safety and efficiency may be concepts that clash with each other. That you cannot be efficient if you're being safe, and if you're being safe, you're not being efficient. And we've seen in Clare's example that you can be very, very productive whilst maintaining high standards of care, and from yours as well. And so the point I wanted to elaborate is how we can harness these concepts to apply them in NHS settings. And I wonder, knowing that I think you've worked with the NHS, whether you have any insights into how you can make this work in wider space.
I think if I was to ask that question to myself in terms of my background and what I've seen and experienced in terms of the environments I've been in, I think if you make every decision based on the patient, which is usually around how they want to be seen, how they want to be cared for, and the environment they're in, I'm in a fortunate position that we can spend money in things to improve them. Therefore, we look for those problems all the time. And what we do is we learn from one another and steal those ideas to make them a better place for a patient to be. So I guess that's the challenge in the NHS. You don't necessarily have the money to spend, whereas in this environment, I probably enable the people I work with to do that. And as simple as things like when you're walking around that building, because I'm I go to multiple buildings, but also see it from a different outset. I try and see it from the patient's eyes, as well as, you know, as a service. So I think if everybody can try and look externally outwards and get that third eye, and just look for those opportunities, because we don't want any kind of compromise in what we give to our patients, but what we want to do is just deliver it better for all of them. So
you have touched on a couple of very important points there. One is I guess in business, the value is defined by the customer, not by the service provider. So in healthcare value is defined by the patient, but often in medicine, the outcomes that we measure, particularly when you're saying how do you measure something less tangible like quality care, it's defined by doctors. Very important example in ophthalmology, the standard of quality in cataract surgery is the absence of a very defined type of complication. And when it's a public sector provider like the NHS, then the ethos is delivery of care to all comers. Whereas I guess in independent sectors, you're bound by patients using your service. If your service users to your patients do not come to you for care, then eventually your service will fail. But it remains the mission of the NHS to provide good service to patients. And the other one is constant learning from other people, and therefore that's the point of the UKOA, this forum that we sat at. So you see that there's representatives from NHS hospitals from all over the country. The idea is that we come and talk about successful, or maybe not even successful, but good learning from each other, so that we can make our services better. I wonder if there's, I guess it's quite nice, sunny spring Friday, and no questions on the chat. I wonder if there are any later questions that people want to ask or discuss. Heidi is asking, Heidi Chittenden from Ashford is asking a housekeeping question, how can access recording? So at the end of this, the UKOA will package this, the slides and the recording, and send them to all members of the UKOA. So you'll get that in your inbox in a few days. Well, I think if there are no other questions, then thank you very much, Tom, and I've already thanked Claire, who's left. And thanks everyone else for attending. The next seminar is in April, it's on Monday, so I won't be present, but our intention is to continue with this monthly and to resume as soon as possible our face-to-face quarterly seminar. So thanks everyone. Thank you, Tom, especially with the short notice. We'll be in touch soon.